Senator Warren had we served on a committee together, a subcommittee on armed services. And we had she had a hearing, and the individual from DOD tried to explain that he couldn't buy American because there's regulation that required him to buy foreign, and then we found out that there was no regulation.
Yeah.
So
I think he has a regulation to buy the cheapest.
Yeah.
So there's always a cheap thing, and that's the problem that we talked about.
he couldn't explain.
He probably didn't know.
Yeah.
We have analyzed those costs for specific molecules among our industrial base, and we've verified that they can be produced by U.S. manufacturers at an equivalent price. What's preventing that is certainty that they will have a long-term agreement to supply it so that they can make the investment. And then secondly, we submitted data for the Congressional Budget Office based on this bill that showed one mustn't think of it as one temporal point in time where an adversarial country or a foreign manufacturer is purposely to drive out all U.S. manufacturers, put the price way below the cost. If you look at it on a 5-year average, as Andrew said, you would save significant dollars because once they drive every U.S. manufacturer out, they increase the price, massive volatility. So it has to be looked at from a budgeting office on a 5-year average basis. And that's not even to bring in what Andrew said. It costs over tens of millions of dollars per shortage of drug within a healthcare system. So they're incurring significant costs of those shortages as well.
You know,
Can we
and
follow up?
I was just going to say, I get really frustrated on this, that people treat risk as if it's free. We are paying a price for risk, for the fact that, yeah, we got it right down to the tightest nickel on how to purchase this stuff, but it's a very fragile system.
You just pay for it another way.
And that's a cost.
Can we go back to what Senator Warren was bringing up? So if we took the DOD and we took the VA, right? If we just took those two, and I'll just take their drug buying. Would that be enough volume to move volume to?
You would transform the U.S. generic supply chain, and you would also cause a force function for private markets to then also now procure from U.S. manufacturers because of the reasons we just said. You don't want a quarter of your pharmaceuticals in an FDA violation site. You want to have certainty in local response time, resiliency. You would fundamentally transform our generic supply chain.
So what percent of the drugs of the generic, let's just do generic, what percent of the generic drugs if the DOD and VA did just their generics, what percent of the volume that come into the country would that be?
You just
Like, is that of 100% of generics sold? What percentage is DOD of that 100% and VA together buy?
Oh, I don't have specifically those numbers, but from a standpoint of moving the market and creating an industrial base, 200 to 300 medicines into generic would cause a significant resiliency base and a U.S. manufacturing base.
Right. And then, Mr. Sedell, you've worked with companies that have opened up plants.
Expanded.
All right. So have they been able to make the price almost equivalent to what's being bought from overseas?
Correct, with new technology. So we're not just saying make it the same way. We're through the private investment in public from state of Missouri and Asper, they're making it in modernized methods. I give you the example. It's like they currently make them in batches the size of this room. Now they make them in equipment that's the size of this table.
So do you have what the return on investment is? Do you know if you were going to invest, how much would it take to open up a plant, and what would be how long would it take to get your money back? Do you have any idea yet?
On some of the drugs, because we're focused on expansion, because there's 30 billion doses of idle capacity in the United States. 30 billion just sitting there. So we're focused on taking those idle facilities that are already FDA approved. What it means is they can get the drug commercialized in less than 5 years, and they get a return on investment in 3 years.
3 years. Okay, so we actually don't have to invest money. If I'm a business guy, if you gave me a 3-year return, I'll do that every day, right?
Absolutely.
I mean, okay, so number one, we can get the cost down. And number two, we can get the investor gets a return.
Correct. The return's so strong that our partners are going and getting their own loans to be able to expand facilities.
So what we got to do is go back to what Senator Warren said. We got to commit volume.
Correct.
So if just DOD and VA did it and that's it, okay?
It'd be transformational.
Okay.
Can I just add, it's in maybe 10% of total volume. I mean, it absolutely would bring domestic manufacturing to the U.S. It would help secure supplies for VA, but it's too small of a fraction to really create change in the rest of the market. So it's not to do it. I absolutely encourage you to do it. This is a perfect thing very sensible thing to do, but we need to think beyond that because we need to sort of change the dynamics in the rest of the markets, in the 90 or so percent in the markets, to change how those markets operate and what they value, and just
I
word of caution.
ran a hospital company, and I was 2% of the entire healthcare dollar, and because I focused on, I could move all the volume in the whole country. I could force everybody to change based on buying, based on quality. Everybody had to change because I was just because nobody would. I was the biggest committed buyer, and the VA. So I think what you said makes sense. But reality is most people are not committed buyers. That's why. If we have real committed buyers, then I think it'd have a bigger impact.
And I'm sorry that Senator Warren left because Senate Finance actually has a proposal on that was put forward last year that exactly does this. The idea for the most vulnerable supply chains, which are a lot of the generic sterile injectables, is to create committed contracts and then have add-on payments for choosing reliable manufacturers. So absolutely the same concept, and we really, it would be great to see movement on that side.
So have any of you done business with the DOD or VA?
Yes, we've done business with the DOD and the VA.
And did they care about quality?
No, so, I was going to bring that up. I commented earlier about technically acceptable, and I think that's a misdefined term in this circumstance. They're not considering resilience, for example. They're not considering the benefit supply chain, and they're viewing that drug overseas as equivalent to the drug domestically made. And I think that's the big mistake. I would say that what we could use would be a DOD set-aside requirement for American-made, for example. I completely agree that the VA could lead the charge. I think you'll find that private hospitals or the commercial hospital business that you're familiar with would actually follow that lead. I think they're ready to recognize the need for resiliency and stability in the supply chain, but you need that big buyer to step up and start the process, and I think that's the VA and the DOD.
And I can confirm what Tony is saying, because we are aggregating demand with healthcare systems and retail pharmacies, knowing that this is a national priority for our nation. So they are willing, as he said, and that would give a further indication to aggregate demand across their systems to procure U.S.-based supply for the benefit of the system.
So for each of you, if you had a choice, there's two different, same drug, and you had one little bottle that said, made in the United States, okay, and the other bottle said, made in China, how many of you would buy, same price, they both look really nice, same little pretty little bottle, how many of you would buy China?
I might want to disclose that my original background is as a toxicologist in this context. I would absolutely buy the U.S. medicine.
Anybody buy China?
No.
Nope. What if it added on there that whether American or Chinese, that it's under an FDA violation, however small, and so there's some website that you can go to see what it was. Would that have an impact on you?
Yeah, clearly we would avoid buying anything that had an FDA violation. When you think about something so sensitive as a drug, right? We're not buying a toy or a vitamin. We're buying something that affects our health in a very personal way. Absolutely, we'd buy quality.
So think about it. The buyers in this country, federal government, hospitals, nursing homes, GPOs, doctors, pharmaceutical chains, right? Have you known any of them that's required they did it based on quality?
No, I regularly do business with all those entities, and they don't really require. They may want to, but there isn't a method for them to assess that quality. As we've been describing, there's really no independent way to measure or report.
But Tony, they could say, I'm not doing it if you haven't had an FDA inspection within 3 years. I could do it if you haven't had, they could do it.
They could do it, for
Yeah.
sure.
Can I add something? So I have studied generic sterile injectable shortages really for 15 years. And transparency often comes up that we don't know, which manufacturer is reliable. But at the end of the day, it's the lack of incentives and the fact that hospitals and GPOs do not fully internalize the harm that comes with it. So the numbers that Andrew commented on.
Can you go through, when you say the harm, how do you define that harm?
Yeah. So the amount of money that hospitals, there was a study, $360 million from additional costs resulting from shortages, right? So it seems like a large number. This comes out
because of costs?
because right, they have to have additional staff and whatnot. That comes out to $60,000 per year. That's nothing per hospital. That's that $60,000 is nothing for a hospital. But if you look at how much
for a day, by the way.
and this is for a year, right?
Yeah.
So if that's the level of the cost, hospitals are very strongly incentivized to buy the cheapest, and in a sense, it makes sense. These drugs are therapeutically
paid for
equivalent,
quality.
right?
We're not paying for quality.
We are not paying for quality. We're not paying for quality. And I will say that I have to disagree with Andrew here. I don't think there's free lunch. If we want to have reliability, if we want to have resilience, if we have to want to have quality, we will have to pay for it. And I think we have to ask ourselves, how much are we willing to pay for it? But there are ways to do it. But you have to change incentives. I think, Civica RX, I don't know if you're familiar with that organization, right? They do a lot of homework around where the drugs are made. They have stockpiles. So in a sense, they have long-term contracts. Hospitals are not signing up for these contracts. They're really wary about this because, oh my goodness, they might actually end up paying more. Right? So we have to change the fundamental incentives and shift sort of how hospitals are thinking about it.
Well, the problem, I used to be in the business, I used to say, nobody came to my hospital because I served Pepsi over Coke, right? So nobody came because I did this, I had this drug or that drug, or I bought my drugs in the United States, or I bought my drugs someplace else. I mean, I got
That's
out
right.
of business 30 years ago.
There isn't accountability for hospitals either. If they have a shortage, they point at the manufacturer, right? So it sort of doesn't, it ultimately ends up with the patient, unfortunately.